Bismillahirrahmanirrahim. Assalamu alaikum. I hope you are all healthy and safe. This is Dr. Fatima from South Surgical, and today we are here to discuss the topic damage control, resuscitation, and surgery. You're already familiar with this topic, and this is going to be a sort of revision for your test. Trauma is the leading cause of death in those under 45 years of age, and most of the victims are young males. The leading cause of death in most traumatic cases is head injury, and the impact of this injury is determined right at the time of impact. The severer the injury, the lesser the chances of survival. Secondary injuries in this case is kind of rare. Hemorrhagic shock, on the other hand, is the leading preventable cause of death in trauma. That is the one thing which is not predetermined at the time of injury. If better management is provided, this thing can be prevented. Causes of shock in trauma. In addition to the hypovolemic or hemorrhagic shock, we can also have obstructive shock, which is due to a cardiac tamponade or tension pneumothorax. A distributive shock, which could be the result of neurogenic or spinal shock or cardiogenic shock. Okay, here we are mostly interested in hemorrhagic shock, which accounts for 40% of all trauma-associated deaths. Hemorrhagic shock is a condition. Shock is a condition of reduced tissue perfusion resulting in inadequate delivery of oxygen to the cells and resulting in cellular hypoxia. Hemorrhagic shock is defined, on the other hand, is the very same condition when it results from blood loss. Looking into the causes of hemorrhagic shock in cases of trauma, one is direct damage to the tissues. Simply, the tissues are severed, the vessels, the blood vessels inside the tissues are severed. At times, there will be direct injury to a blood vessel. Plus, there is a compounding element, coagulopathy, which adds to the direct trauma and the direct loss of blood, which was enough to cause shock on its own. Coagulopathy of trauma is one of the single most accurate predictors of prognosis of trauma, and it is one of the most significant yet difficult challenges for the doctors to deal with during damage control resuscitation of the patient. Trauma-induced coagulopathy, acute traumatic coagulopathy, it is defined as intrinsic deregulation of blood coagulation in the setting of trauma, right? This is intrinsic to the system without any external factors into consideration other than that trauma. Prerequisites for this is physical tissue damage and tissue hyperperfusion, or it results in what? One, endothelium, it releases the tissue plasminogen activator, and that in the long run results in fibrinogen depletion. On the other hand, endothelium expresses thrombomodulin. This would, in the long run, inhibit the extrinsic pathway. This leads to systemic anticoagulation. This is the direct effect of trauma and hypoperfusion of tissues on coagulation. In addition to this, there are other exacerbating extrinsic factors. These include hypothermia, which adds a notch to this, and dilution by administration of crystalloids and blood products, that also adds to this. In addition to that, acidosis, which results from tissue hypoperfusion, is also a contributing factor. So these three are extrinsic factors, while there was an intrinsic dysregulation at hand already. When we look at hypothermia, that is the first of the extrinsic factors, we see that severe hypothermia is associated with a high mortality. Hypothermia is usually the result of the pre-hospital setting. The patient may be found in a cold environment in the pre-hospital time. Then when he's brought to the emergency, exposure during that to cold fluids and exposure of the patient to examine the injuries, that also results in hypothermia. When it's taken to the OT, and the patient is obviously half exposed, and during the surgery, there could be exposure of the peritoneum and washing of the peritoneum. And if these fluids are not warm, all these factors contribute to hypothermia. Hypothermia becomes clinically significant when it is less than 35 degrees Celsius or more for more than 4 hours. If this remains at this temperature for more than 4 hours, that can lead to cardiac arrhythmias, decreased cardiac output, increased systemic vascular resistance. Plus, as we've already looked into, it can interfere with the clotting cascades. At 35 degrees, there is platelet dysfunction. If the temperature goes down further, at 33 degrees, there would be disruption of the clotting enzyme synthesis and kinetics. Not only is the synthesis stopped, but their kinetics are also stopped. The plasminogen activator is also inhibited. It's progressive delay in thrombus formation. Second factor, which is an external factor contributing to coagulopathy and on the person himself, is acidosis. Acidosis is a direct result of the shock itself. Uncorrected hemorrhagic shock would lead to inadequate cellular perfusion. As a result of that, there will be anaerobic metabolism. Again, no oxygen in the game, and so anaerobic metabolism is the result of that. That will cause lactic acid production, and this will result in metabolic acidosis. This again contributes to coagulopathy. Acidosis by itself, it can decrease the contractility and cardiac output. Okay? This is when it is around 7.2. It can lead to vasodilatation, hypertension, bradycardia, dysrhythmias, decreased flow to the liver, quite a few things on its own. Right? Or the measure of acidosis, lactate levels or base deficit. These are the measures and they give a pretty accurate account of the situation. Yes, so lactate especially is a very accurate measure of the state of shock in a person. These things together, coagulopathy, acidosis, and hypothermia, they are called the triad of death in trauma. Once the patient is sort of lured into it, the deeper the patient is surrounded by these, the lesser are the chances for the patient's survival. Right. Damage control resuscitation is our topic for today's discussion. And how is this related to the picture? We'll come to that in a bit. Damage control, the term itself is coined from the naval shipbuilding this here we see is a ship which is about to sink. The shipbuilding agencies, the shipbuilding companies and factories, whatever, they build these ships on a principle that sort of guarantees to some extent that if a ship is injured during the course of its travel, minor repairs will prevent it from sinking. And it will be able to make it to the shore where it can be repaired properly, right? So minor repairs at the spot may save the ship from sinking in the long run, right? This principle has been used in medicine, and the concept of damage control resuscitation is sort of based on that. We define this as a systematic approach to major exsanguinating, yeah, hemorrhagic trauma, which incorporates several strategies to counter the triad of death and hence decrease mortality and morbidity. जो strategies resuscitation में include हुए हैं, these are permissive hypotension, hemostatic resuscitation, and hemorrhage control या damage control surgery. ठीक है? We'll look into each of them in detail. और इन तीनों का जो ultimate goal है to break this triad and get the patient out of it. Why we need damage control? Multiple trauma patients, they are more likely to die from their intraoperative metabolic failure than from a failure to complete the operative repairs. Okay? So at an initial stage in the damage control, it is more important to deal with certain particular points and not the rest of the anatomical details. See, treat first what kills first. Deal with the hemorrhage, deal with controlling of contamination and stuff, deal with the acidosis and coagulopathy, and we can deal with anatomical repairs and details at a later stage when the patient is more stable. That is the basis of damage control resuscitation. Initially, this was the plan of events that used to take place. The patient was brought to the emergency room where he was resuscitated with cold fluids, and an effort was made to sort of resuscitate the patient to a normal value. And that used to take a long time. Then the patient would be brought to the operating room or the OR, और वहाँ पे there would be a long surgery जिसमें तमाम चीज़ें repair हो रही हैं और details में anastomosis हो रहे हैं and stuff like that. And this entire thing would take so long that it would actually be a second insult to an already injured patient. Okay? The result of that was that most patients with severe trauma did not survive. With regard to damage control surgery, this concept has changed. A patient is brought to the ER where resuscitation and initial examination is just started. And the patient is immediately shifted to the OR or the operating room where most of the resuscitation is conducted along with the surgery, right? The surgery is, we'll come to that in detail, is abbreviated or shortened compared to the surgery that used to take place over here. After that, the patient is shifted to the ICU where his resuscitation is completed and is actually stabilized. He's brought to a condition where he can actually tolerate a more definitive surgery, right? According to your Bailey and Love, he divides, categorizes the damage control into stages. The first stage is that of patient selection. This is the ground zero stage when the first patient is brought to the ER and the resuscitation has to be started. Here is when we actually make a decision as to whether the patient needs damage control surgery or a regular sort of surgery. Okay. Once you have an idea of that, the patient is immediately shifted to the operating room where the resuscitation and a limited operation are conducted at the same time. The resuscitation is then completed in the ICU and definitive surgery comes after that. First of all, we would come to selection of patient. How do we recognize the risk of hemorrhage as early as possible? There are certain signs and symptoms. There's nothing short for a good examination, right? A combination of altered mental status, cool and clammy skin, and absent radial pulse. This is a triad which indicates hypovolemic shock. Okay? Plus the shock index, which is heart rate divided by systolic blood pressure. It is a better index of shock than just hypotension in one reading. Plus अभी जैसे हमने पहले भी देखा है कि lactate and base deficit plus spike carbs They are excellent indicators of a state of shock because they are showing us a state of hypoperfusion, hypoxemia at the cellular level. This is your table, which shows us classes of hemorrhage. And we're just going to look at the fact that pulse, and the mental status, slightly anxious, mildly anxious and confused lethargic. ठीक है? ये दो तीन factors plus urine output, it gives us a great indicator of the state of shock that the patient is in, the depth of shock that the patient is in. Then there are scoring systems that can help us assess the situation in such a way that we can make a quick and early decision regarding whether to go for damage control surgery. In those तीन systems, and we are just going to look at the ABC scoring system, which takes into account the mechanism of injury and the findings at fast or systolic blood pressure and heart rate. Okay? If all of these things are positive, that is a score of 4. There is a 100% chance that this patient will need a massive blood transfusion and will need damage control resuscitation, right? Score of 2 is like 75% sensitive. इस किस्म के स्कोरिंग सिस्टम्स आर मेड ताकि इंसान को जज करने में देर ना लगे and the patient can be dealt with immediately as quickly as possible. Okay, now we come to the strategies. एक patient हमने select कर लिया है. We have an idea that this is the patient that we are going to deal with in this way. Permissive hypertension and hypotension is one of the first strategies that underwent a change in 1980s, I think. Initially, the patient's state of shock was corrected. An effort was made to correct it to normal. This has changed. Okay? Permissive hypertension may keep the blood pressure low enough to avoid exsanguination. Because if you think of it, आप एक दफ़ा blood pressure को normal कर देते हैं, तो the bleeding will start again क्योंकि अभी तक bleeding हमने पकड़ी नहीं है, right? If the bleeding has not been controlled yet, then do not raise the blood pressure to normal. Raise it just enough to get minimal end organ perfusion. Okay? If you raise it further, there will be clot busting. The clots which have now sealed off the injury to some extent, they will disrupt because of the increasing or normalizing blood pressure, and they will be bleeding once over. Right? We want to prevent that. Plus, if you give too much of fluids in the form of saline and all that, there is consequent hemodilution, and that will promote coagulopathy, right? And we want to prevent that. See, here we are, by using permissive hypertension, we are attacking the coagulopathy part of decreased coagulation limb of this triad. What we are trying to do is prevent dilution, right? And promote just enough end organ perfusion to reduce acidosis. We are sort of trying to cut through this triad. When to implement permissive hypertension is when there is a potential for uncontrolled hemorrhage. When you have not actually got hold of the hemorrhage yet. Okay? At times when there is external hemorrhage, suppose a limb is bleeding or something and you apply a pressure bandage, you sort of have controlled it to some extent. Lekin person who is bleeding on the inside, जिसमें आप अभी तक hemorrhage को control नहीं कर पाए, उसमें you do not want to raise the blood pressure to an extent कि the bleeding will start all over again. जो अभी तक कुछ bleeding को body ने control किया है, you don't want to start that all over again, right? So titrate small boluses, 250 mils of fluid administration to a hypotensive or a minimally normotensive goal. The systolic blood pressure of 70 to 90 is considered to be optimal for this. The goal of permissive hypertension is to bring the systolic blood pressure to about 70 to 90 millimeters of mercury. This is just enough to get a good tissue perfusion, minimal tissue perfusion, without increasing the blood pressure to an extent that the clots would be busted and there would be a rebleed. Okay. Normal ventilation and a palpable radial pulse around 80 is an indication your goal has been achieved. Okay. The patient is sort of responding clearly, it's not confused, and PP of right this much is normal. PP को 100 and 120 पे ले जाने की जरूरत नहीं है. Contraindications of permissive hypertension are principally traumatic brain injury and pregnancy. ये भी absolute नहीं है. These are also relative or measuring the amount of requirement. We have to get to a balance between the damage that hypotension may cause in case of a traumatic brain injury compared to what damage compared to the damage that hypotension may cause if there was a rebleed. Okay, next up is hemostatic resuscitation. ठीक है. Hemostatic resuscitation का क्या मतलब है? We'll come to that in a bit. Okay, let's start. Is the administration of large boluses of isotonic fluid an optimal therapy for acute hemorrhagic loss or severe traumatic injury according to massive or requiring massive transfusion? ठीक है, यहाँ requirement इस वक्त है हमारे पास acute hemorrhagic loss or severe traumatic injury. Isotonic crystalloids, is that an option or is that a choice? It is an option, but it is definitely not a choice. Crystalloids, they can cause dilutional coagulopathy. They cannot increase the oxygen carrying capacity, so they are sort of useless in that regard. If they are not warmed up properly, they can cause hypothermia. Since they do have an element of chloride in them, normal saline, they can cause a hypochloremic acidosis, actually accentuating the acidosis. Plus, with no active molecules in the saline to hold the fluid in the circulation, they leak into the extravascular tissues, resulting in edema, and only just a tiny fraction remains inside the blood vessel. So you have to give a massive amount, and that further compounds it. This is the relationship of fluid given to coagulopathy. The more the fluids, the more the chances of coagulopathy. Next up, we look at resuscitation with blood components. This is the basis of hemostatic resuscitation. Okay, we are preventing coagulopathy. Really identify the risk group and act before the coagulopathy actually starts. So you can start after it starts, but it is better if you start early during the course of resuscitation. The components that are used are packed RBCs, fresh frozen plasma, and platelets. Okay? And there has been a bit of a controversy regarding the ratio of these. Usually packed RBCs and FFPs should be given in a ratio of 1:1, and the packed RBCs or platelets are given in a ratio of 4:1. Okay? Plus fibrinogen and calcium also they have to be added. Resuscitation with blood components early during the course of resuscitation is the key to saving them, right? Or a established ratio between these is also 1:1:1. It is considered in certain studies to be the most beneficial ratio. Sort of mimics the actual thing that the patient has lost, right? This is a chart showing the requirement of different components, the amount of different components for different weights. And since we are talking about adults in this scenario, above 50 kgs, 4 units of packed red blood cells, 4 units of FFPs, and 1 unit of pooled platelets, plus 8 units of cryoprecipitate. Yeah. Okay. These sort of make one pack or the initial pack that is given to a patient who requires massive transfusion during the course of damage control resuscitation, right? Massive transfusion protocols, they have been set up in most hospitals, and this is an algorithm to sort of show the steps that are taken once a severely injured patient is brought over, right? This has made the entire resuscitation process much more systematic. As soon as the patient comes to the emergency, the blood bank is informed. They get the blood group and they arrange packs according to that. ठीक है? So that उसको उस वक्त ब्लड अरेंज करना एंड क्रॉस मैच करना और उसकी इन्फेक्शंस चेक करना एंड ये वगैरह वो सारा कुछ ना हो. As soon as you know the blood group of the patient, you have a ready pack available जिसमें इतने RBCs और इतने platelets और इतने FFPs सब मौजूद होंगे ready for the patients that particular group. Okay. In addition to the blood products, a part of an adjunct to the hemostatic resuscitation is the tranexamic acid, TXA, or commonly known as transamine. It is an antifibrinolytic agent, and it has been proved in studies to increase the survival with no thrombotic complications. Okay? It should be given early, and it should not be given more than 3 times in 24 hours. Once the risk of hemorrhage or hemorrhagic shock is determined, 1 gram is given start, and then 1 gram is given over 8 hours. The contraindications are once again the thrombotic kind of phenomena. People who are already prone to this may run a risk, but normally it does not cause thrombotic episodes. Another adjunct is recombinant factor 7A. The use of this has been shown to reduce the requirement for transfusions, but in the long run, it has been found not to contribute to reduction in mortality. Okay? It does not reduce the mortality in the short run or in the long run, neither immediately nor later. Okay? The use of this is it's kind of controversial, and the role of this factor is more of its use is limited to those people who are not responding to massive transfusions. You've already given them massive transfusion protocol, you've given them RBCs and platelets and fibrinogens, and yet they are not responding to that. So this is given an adjunct to support that treatment. Otherwise, it is not a very useful thing. Now, after we have begun that initial process of resuscitation, with permissive hypertension and hemostatic blood components resuscitation. Next, the patient is moved to is already in the OR actually. Indications for damage control surgery. These include an inability to achieve hemostasis in the emergency. Yeah, we can't do that. And there's indication towards complex injuries, for example, like liver and pancreas, say combined vascular, solid components, solid visceral, and hollow organ injuries. Plus venous injuries, retrohepatic vena cava is an inaccessible kind of area, difficult to reach area, something like that. Then anticipated need of time-consuming procedures. यहाँ तरह तरह की injuries हैं, 3-4 anastomosis करने हैं, फलानी repairs करनी हैं. एक ऐसी सर्जरी जो 6 घंटे लगाएगी, पेशेंट उसे टॉलरेट नहीं कर सकता. उसमें we should opt for a damage control procedure. Physiological चीजें जो हैं, includes the hypothermia of less than 34, a pH of less than 7.2, lactate of more than 5, जबकि normal is 2, PT of more than 16, etc., etc. If the patient has already been given 10 units of blood, so they'll go for this thing. And if the operating time is estimated to be more than an hour, maximum of 90 minutes, and do anything more than 2 hours, then do not go for a long procedure. See, if one or two of these factors are present, then damage control surgery is our choice. If all of these are present, then we probably will not be able to save our patient. Principles of damage control surgery. ठीक है, तो strategies of damage control resuscitation हमने already देख लिया, वो क्या थी? Permissive hypertension, hemostatic resuscitation, and damage control surgery. Damage control surgery के मजीद जो principles हैं, they are control the hemorrhage, prevent contamination, and avoid further injury. And that's it. Do just that and come out. You can buy patient some time so that you can deal with it in much greater detail once the patient is more stable. Steps of TCS laparotomy include initial laparotomy, which means opening up the patient's abdomen. Okay, you identify the main source of bleeding. You hepatic packing, superior and inferior. Small hollow viscous perforations can be rapidly closed. Resect all non-viable gut and close their ends. You don't have to anastomose anything. Minor injuries not involving the duct, no treatment. अगर distal pancreatic duct injury है, तो you have to do a distal pancreatectomy. Otherwise, you can keep leaking and making life miserable for the patient. But no anastomotic procedure is done at that time. Packing of organs or spaces to control inevitable coagulopathy. This is important. See, there is always a chance of coagulopathy in this scenario. So you have to make sure that जो भी open spaces हैं, they should be packed ताकि वो ooze ना करें और वहाँ पे pool of blood इकट्ठा ना हो. वहाँ पे pressure होगा तो they will not get a chance to ooze, right? Abdominal closure in this damage control surgery, damage control laparotomy is temporary. Okay? It can be done using either it can be left open, we use silo bag or a vacuum pack or a towel clips, anything of that sort of to temporarily close the abdomen for 24 to 48 hours. Here are some pictures from a damage control surgery. Here you can see a massive liver injury. Yeah, both the lobes have been practically torn off. Once this area is cleared, what to do? Pack it. A pack goes above the liver, a pack goes under the liver, right? And the liver is sort of squeezed between the two, and this way, the whatever is inside will be checked. Any bleeding inside will be checked because of the pressure of these two packs. Yeah. Other measures of to be able to control hepatic bleed is use of a Foley catheter. The catheter is introduced and the balloon is inflated, and that gives a balloon tamponade effect, right? It sort of exerts pressure on the cavity, causing the bleeding to stop. Same here. This is an other example of tamponade, which is given into that area, and then it works. This is an example of closure. A silo pack is applied to the abdomen and it's just a temporary closure. You have a simple artery hemostats नहीं sorry towel clips के साथ abdomen has been temporarily closed. एक साइलो बैग ही की एप्लीकेशन की जो टेक्निक है वो ये है कि a layer of offsite is placed on the abdominal contents. ठीक है, उसके बाद एक gauze packs are applied to this area और इसके अंदर ही drains are placed, and then another offsite or plastic or occlusive layer is applied right at the top. This is a method of temporary closure. Damage control orthopedic surgery. Stable patients may osteosynthesis, yani bones are reformed and all that. Lekin polytrauma mein just external fixation. Do not go for perfection in these cases. Do not manipulate the long bones too much. That can actually cause fat embolism, and you do not want to add another insult to the injury. Right? So minimal external fixation and just alignment. Anatomical perfect alignment is not required in these cases. In cases of damage control neurosurgery, evacuation of hematoma, arrest of intracranial hemorrhage, closure of dura to prevent infection, and craniectomy. to prevent compartment syndrome. These are the basic steps. Okay, after you have completed the damage control surgery, you have so-called closed the temporary, achieved temporary closure of the situation. The patient is then either shifted to the ICU or an interventional radiological suite. क्यों? Because at times surgery के दरमियान भी you are unable to control certain kind of hemorrhages. Yeah, for example, liver met can often happen that you are unable to perfectly seal off the vessel. हमने सिर्फ पैक किया है उसको, रिमेंबर हमने हर चीज़ को टाई ऑफ नहीं किया. पैक करने के बाद हम इंटरवेंशनल रेडियोलॉजिस्ट के पास पेशेंट को ले जाएंगे और वहाँ पे दे कैन एम्बलाइज द ब्लीडर. ठीक है, टेक केयर ऑफ द ब्लीडिंग, गेट रिड ऑफ द हेमरेज once for all. After that, the patient is brought to the ICU. That is the stage 3 or the resuscitation stage of our patient. यहाँ पे the stage will last for from 24 to actually 72 hours, but up to 48 hours is really crucial, and this is the time where we can actually revive our patient. We can get the patient out of our deadly triad and on the way to recovery. What we do is correct the metabolic disorders, the acidosis. There is vigorous core rewarming. Core rewarming के लिए the stuff that is used for that is the bear hugger. This is attached to a blanket which covers the patient, and there is hot air pass through it or keeps the patient warm. There's warming lights, warm fluid, blood products. That has to we have to make sure of that. Plus, there is a method for continuous arteriovenous rewarming when the blood actually is pushed through a machine which warms the blood up and pushes it back into the body. Right. There is correction of residual coagulopathy. We have already started that in the pre-op stage, and then all through the operation, we have given the patient blood products, okay, RBCs, platelets, fresh frozen plasma, and cryoprecipitate, the whole pack, right? Okay. If any residual coagulopathy is still there, you correct that. Complete. The patient has to be on ventilatory support throughout this phase, right? Restoration of normal cardiovascular state by infusion of fluids and blood, use of inotropic agents if needed, and supportive care for the starting lungs and kidneys. Okay. This is the ICU care time. This will bring our patient back. It will stabilize our patient to an extent that he can now withstand another more definitive procedure. Stage 4 is reoperation, right? Indications for definitive surgery. अभी एक हमारा पेशेंट आईसीयू में था and we were working on our patient, stabilizing him. The core temperature has been brought to 36 at least or above, closer to normal. The acid-base balance is now correct. Normalization of coagulation profile. ठीक है, basically वही जो हमारा triad है वो हमारे काबू में आ गया है. The deadly triad is now under control, and now we can undertake further surgery. The window of opportunity for surgery is like 24 to 48 hours after trauma, between correction of metabolic disorders and onset of SIRS and MSOF. ठीक है, क्योंकि अब आपने जो आधे आधे काम किए हुए हैं और बंद की हुई gut and stuff like that, you just have like 24 to 48 hours at hand. Just you should deal with that. Otherwise, the disturbed anatomy will start taking its toll. Window of opportunity for definitive osteosynthesis is 5 to 10 days after orthopedic trauma. Patients sometimes need an unplanned operation. ये होता है at times जब there is a rebleed. सारी packing के बावजूद एकदम the blood pressure goes down, the pulse goes up, and there is a rebleed, or ये कि there is intense infection, peritonitis, or compartment syndrome, and you have to open the patient before the ideal time without actually the patient being completely stable. Okay. Now we have opened our patient for the second time. अब हमें क्या करना है? First thing, removal of the abdominal packs जो हमने सारे रखे थे. उसके बाद अगर कोई रेजिडुअल ब्लीड वगैरह है, टेक केयर ऑफ दैट. इतनी देर की पैकिंग के बाद तमाम ब्लीडिंग इज, और जब आप coagulative measures सारे कर रहे हैं, तो bleedings are usually controlled by them. Plus you remember कि हमने we got the hepatic arteries and stuff like that embolized by interventional radiologist. Completion of definitive repairs, वो तमाम gut जिसको हमने simply ends बंद करके छोड़ दिया था, अब end to end anastomosis will be done. Then search for any missed injuries जो उस वक्त जल्दी में और पैकिंग के दरमियान हमें नहीं पता चली और ब्लीडिंग की वजह से छुपी हुई थी. Look for any missed injuries and deal with them. Copious washout should be performed. Obviously उस वक्त हमने कुछ भी नहीं किया था अलावा पैकिंग के और फटाफट ब्लीडिंग रोकने के, राइट? इस सिचुएशन में आप अच्छी तरह you will clean everything out to complete lavage of the peritoneum and then formal closure of the incision. ये part is kind of tricky because this might not always be possible. There might still be edema of the tissues and abdominal closure is not possible. Agar it is possible, it is closed completely right then. Otherwise, if it is not possible easily, a next step has to be added. Okay, first step of abdominal closure. This step mein, the abdomen is closed using a mesh, which is sort of a skin graft can be applied on top of that or something. And later on, a formal repair can be done at a further later stage. Like if the abdomen can be closed, so the best thing to do is close the fascial sheets, the fascial plane of the abdomen, right? If that is not possible, to close at least the skin. Do the minimum possible if the abdomen can close without tension, right? If can not, तो फिर हमारे पास option क्या है? Apply a mesh, cover it with skin graft, and do a formal repair further on. Complications of damage control surgery. These include sepsis and multi-organ failure. There can be pneumonia. Obviously, you have packed everything up. Intra-abdominal abscesses. That is also true. Indirect fistula, compartment syndrome. Yeah, मगर none of these things except compartment syndrome, जिसका chance इसमें ज़्यादा होता है, all of these things can result after any other surgery, right? किसी भी multi-injured patient में, severely traumatized patient में, all of these things can happen और ये सिर्फ damage control surgery का नतीजा नहीं है. सिर्फ compartment syndrome का chance इसमें थोड़ा ज़्यादा होता है क्योंकि हमने सारी पैकिंग वगैरह करके ऐसे बंद किया होता है. Summary: resuscitation. For a damage control resuscitation in a severely injured patient, which is carried out mostly in the operating room, okay? Not in the ER, exposing the patient to cold and all that. Using biologically active fluids, that is blood, okay? ये hemostatic resuscitation है. Our fluid is not on saline, not salines, but blood and blood products, blood components, namely RBCs, platelets, fresh frozen plasma, and cryoprecipitate. This is called damage controlled resuscitation. Or इसमें, do remember the concept of permissive hypotension. Do not raise the blood pressure to an extent that there would be a rebleed. The surgery is performed in a minimum, is the minimum needed to stabilize the patient. ठीक है? क्या करना? क्या principles थे इसके? Control hemorrhage, control contamination, and do not injure any further. Aims of surgery are to control hemorrhage and limit contamination. Secondary surgery is aimed at definite repair, and this is usually undertaken 24 to 72 hours after the initial procedure when the patient has already been stabilized in the ICU. Okay. If there are any questions? Hello, beta. अगर वो क्वेश्चंस वगैरह अगर कोई हैं तो उसके लिए कर दें इसको. लेक्चर मेरा खत्म हो गया है. अगर वो क्वेश्चंस जो एंड पे होता है क्वेश्चन एंड आंसर्स का कुछ या नहीं? हाँ, अच्छा बोलेगा, नहीं समझ आ रही. एंड पे क्वेश्चन और आंसर्स का होता है कुछ, अगर किसी ने कुछ पूछना हो बताना हो. हाँ, कैसे क्या करना है बताओ. मुझे नहीं पता ना. Thank you for your attention, everyone. If there is any question, though, please go right ahead.